her, bold, brave, her, with Dr. Pam Peeke.
Hi, I'm Dr. Pam Peeke, and this is episode number 534 of the Bold and the Brave, Her podcast. Today, I'm joined by someone I have been wanting to meet for a very long time because I have worked on the board of trustees of the American College of Sports Medicine. I'm now on their foundation board, and now I'm working with the Senior Olympics. And I wanted to talk to this one expert in all things women and physical fitness throughout the lifespan. Her name is Dr. Maria Fiatarone, and she is an academic and clinical geriatrician, board certified in internal medicine and geriatric medicine in both the USA and Australia. I'm actually talking to Maria as she is in Sydney. So I want you all to think about how long it took us to figure out how to schedule this one. And she spent 10 years at Harvard and Tufts Universities after a Geriatric Fellowship at UCLA, and has held the inaugural John Sutton Chair of Exercise and Sports Science and Professorship at Sydney Medical School since 1999. That is some incredible longevity. Maria, welcome to the podcast.
Thank you.
Good heavens. Oh my. No, just absolutely crazy good. All right. So I have become acquainted with your work through a number of my academic colleagues. And one of the things I was so impressed with was the fact that you're a physician and an expert in exercise physiology. Many times on our podcast, we have our wonderful PhDs in the field, but the fact that you're also a geriatrician and a physician really was frosting on my cake, and hopefully is going to help enrich all of us in our own knowledge base on what happens with a woman as she courses through her lifespan with regard to physical activity. Sometimes I don't use the E word, little exercise. I just say physical activity so people don't start running to the exits. So I just think that the time is now to be talking about this because there's just such a push toward proactivity, no matter the age. And there's always hope for being able to reach some level of optimizing your health span, the years of robust and vital life, and hopefully making it as close to your lifespan as possible on the overall. So let's take it from the beginning. First of all, I just want to ask you something about your background. You and I are basically peers in many respects. And at one point when I finished my residency training at George Washington University, I actually was thinking of looking at geriatrics. It wasn't cool and it wasn't, like the place to go when I was doing my medical education. And I actually, ended up doing some interviews and oh my God, the program wasn't the world's greatest. And I was just really underwhelmed by the lack of innovation and forward thinking as it related to geriatrics. I just saw a lot of stereotyping. And so I backed off and I ended up in critical care instead, and also internal medicine. But for you went where no woman goes, and that is you. You went right into geriatrics. What the heck? I mean, years ago, it wasn't a place to be. What was going on in your mind? I'm really curious.
Well, it's actually all due to my grandmother, I have to say. So my grandmother was very close to us and did a lot of caring for us after school. And she and I used to watch Jack LaLanne on TV every afternoon together when I was little. And she was kind of a health food nut before that was a thing. And so she always, talked a lot about nutrition and exercise and being healthy. And one day she fell off a ladder when I was in high school and broke her hip. And it was in the 1970s, and there was no geriatric medicine. And I was planning to be a vet, actually, at the time. And she ended up with all of the horrible complications that you can imagine from a hip fracture at the time, with delirium and decubitus ulcers and a stroke and malnutrition, and went down to like a skeletal sort of version of herself, and ended up living with us, but being, very impaired from all of that mess. And so I decided at that point that I needed to become a doctor and needed to actually invent this field of geriatric medicine, which didn't exist at the time when I went to medical school. And I'd always been quite active in just sporty things anyway. And so when I was in medical school, I used to tell my friends that I was going to create a geriatric sports medicine clinic. And they're like, what are you going to do? And it was just, a crazy idea. And so I did my residency, did the very first fellowship in geriatric medicine in 1985 in America, actually, at UCLA. And then when I finished that, I was lucky enough to go to Tufts, where Bill Evans was working and heading the sarcopenia lab. And Irv Rosenberg had just invented the word sarcopenia in 1986. And so I worked in that lab, and we decided to apply what they were doing to sort of younger, healthier men to the nursing home patients that I was taking care of at Boston, at the Harvard nursing home there. And that's really where it began. And I hadn't really thought about muscle and sarcopenia and things till I went to that lab, but it became quite clear that a lot of what we were dealing with in geriatric, the big syndromes of geriatric medicine, had a lot to do with sarcopenia and loss of fitness and things that were quite complementary to the standard sort of medical care. So that's really how it began. Yeah, it's all really due to Jack LaLanne and my grandmother, I have to say.
Okay, so define for everyone sarcopenia.
So sarcopenia was defined by Erwin Rosenberg in 1986 as the loss of skeletal muscle mass and function with aging. And the reason he came up with, he was actually a nutritionist, a gastroenterologist, and he used to go through the wards at Tufts Hospital and see patients, and he would always, look sort of under the sheets and see these skinny little legs sticking out. But it was something nobody was talking about. And he came to realize that a lot of their frailty and disability was due to this loss of muscle mass, but it had no name and it had no drug. And so people weren't paying attention to it. So he thought, well, I'll name it something similar to osteopenia, osteoporosis, which people are familiar with. And maybe if I name it, they will come. Per Kevin Costner. And so he did. And that was really the beginning. And then the lab was called the Sarcopenia Lab. And that's where we began looking at, muscle and all of the changes with aging that occur and how we might prevent them.
You made me remember something. I've been working in the fitness industry for many years with a lot of the bigger national groups here. And I was asked to give a keynote for IDEA, the big international dance exercise aerobics. And at that time, Jack LaLanne had just died. He passed away. Lord knows he was 90 something. And his wife, if you remember her name, is Elaine LaLanne.
Yep.
Okay. So
Yep.
A little hard to forget. And what was interesting was she was going to accept his Lifetime Achievement Award. And so she and I were backstage. I mean, there were like 4,000 people, maybe 5,000 people in the audience outside. And we were just playing around in the back. And she was hysterical. She's a little tiny person, and quite compact and, needless to say, in great shape and whatever. And then she went out there and, did her little Lifetime thing. And then as I went out and did mine, as I began mine, I said, I want to do something wild and crazy because this is kind of the way I am. So I said, Elaine, come on out here for a minute. And so she came out and we did push-ups together on stage. All right. Now, mind you, I was in high heels and a dress. This was not exactly ideal. And it was hysterical. So we were counting them out. And here she was hammering. Okay. She was not exactly 20. Okay. She was older, like really older, like 80 or something ridiculous. And so I'm hammering away. I'm going, oh my God, something occurred to me. I had this nightmare thought. What if I can't keep up with her in front of 5,000 people? So what we decided to do was cut it off at 20. So we do, 2 sets of 10, and she was just hammering away and having a good time. And she just thought the whole thing was funny. And I was like, oh, thank God. Oh my goodness gracious. Such great memories, to say the least.
Legacy.
All right. So that's how you did your thing. Okay. And then, exercise physiology came after, the Geriatric Fellowship. You were starting to incorporate it, and then you actually brought it to full fruition when you came to Australia, right?
Yeah, well, I mean, at Harvard for the 10 and Tufts for the 10 years I was there, that's what we were doing basically, was applying exercise therapy to geriatric patients. And so we were looking at sarcopenia, osteoporosis, depression, heart failure, renal failure, arthritis. So basically all of those studies were done at Harvard and Tufts. And then, when I came to Australia, I continued that, working within the School of Exercise and Sports Medicine, which didn't have any other physicians in it. I was the only physician. The rest of the people were exercise physiologists. So
right.
Over the 25 years or so that I've been here, we brought a lot more sort of health issues into the exercise physiology curriculum. Hasn't really gone the other way. The medical school doesn't have any exercise courses still, just like when I was in medical school in 1977.
That's just
Nothing has changed.
Insane.
Nothing has changed. So that's the hard part, is trying to get physicians to kind of incorporate it into their standard practice. And it hasn't happened, I have to say. So the stuff that we do is, in some ways, comes from the ground up. We get a lot of referrals, from patients themselves who want to use exercise as medicine. And physicians, like GPs here, do refer me lots of patients to my clinical practice. So they are beginning to recognize. The thing is that they still refer people pretty much for mobility or frailty. They don't really necessarily refer people for treatment of their medical conditions. But being a geriatrician, everything's related to everything. And so when I see people, it's holistically kind of, head to toe. And I always see ways that exercise could improve the standard care of all of their conditions. Essentially, there really isn't, any medical condition pretty much that can't be improved with the addition of some kind of exercise. And often the older they are, the more often it is resistance training, because that's kind of the underlying deficit that they pretty much all have, unless they have been, habitual weightlifters over the years.
Mm-hmm. Mm-hmm. Okay, let's start in. Okay. There's a little girl out there somewhere, and she's going to play, and she's just going to have a good time. When do you really start thinking, like if you're a mother right now, when do you start thinking about the fact that you need to lay down a strong foundation of physical activity in a young girl's life?
Right. Well, I mean, there's actually a study in 3 to 5 year olds looking at, it's not an intervention study, it's just an observational study of kids in the playground, and looking at their activity levels by activity monitors, obviously, and then looking at their bone density. And even at that age, the ones who are more physically active have considerably higher bone density, 10% higher, so both boys and girls, at that age, 3 to 5 years of age. And, you could say, well, it's genetics. People are genetically blessed to, have better bones, also just for whatever reason want to move around more. But then, you get to the actual intervention studies in childhood, and you can see that, activities that include bone enhancing activity like jumping and that sort of thing, absolutely increase bone density, and particularly pre-pubertal. So if you can exercise in a way that is healthy for bone and muscle before puberty, it actually works much better than if you don't start till after puberty. Still works, and puberty obviously is younger and younger these days, even as young as 8 sometimes. So remarkably enough. So there isn't really a time when it's too early to start. And I think a lot of what we have kind of, morphed to in recent years in terms of parenting. I mean, I have 7 children, so I do know a lot about children. I'm not a helicopter parent. I never was. But there are a lot of, parents who are very much protective of kind of the movements of their children. And I remember when a couple of my twins were in grammar school, and the new rule came out, you couldn't run on the playground. And why was that? Well, somebody fell off like a jungle gym thing and broke their arm. And, I wrote a letter to the principal. I'm like, don't you understand if you prevent children this age from running, you're just setting them up for a hip fracture at age 80. That's all you're doing. And, so you prevent a wrist fracture at age 10, you get a hip fracture at age 80. But that concept of, putting children in bubble wrap is really quite prevalent. And we're not thinking enough about the long-term consequences, particularly for bone, which peaks at age 19 in your femur, right? So that's the most bone you're ever going to have at age 19. So if you haven't actually accrued it by then, all it is downhill from that point. Muscle, you get a little more time, get another 10 years or so before you're at peak muscle mass. But it is pretty young when it starts. So I would say, that we need to be thinking about the long-term consequences of, and we think a lot about sedentary behavior, but I think we also need to think about, they're not, they're very different. They're not the inverse of each other. So we need to not only not let children sit, but we also need to think about, healthful versions of physical activity, which mostly are play when you're young, but it's play that we used to do that isn't done so much anymore, skipping and hopping and jump rope and double dutch and, all the things that we used to do that involved jumping. Those are incredibly healthful, and they don't require, structured time and, playing dodgeball and, all the things we did at recess now, which are kind of gone away, are the things that kids do need to do. And there is obviously a lot of organized sport, which is good. But not every child, is a candidate for an organized sports team. And so, that tends to kind of select out the more, elite sort of versions of the children. And we need something that is available to everybody, that, that is not requiring people to be competitive on a team, because not everybody is into that. And so I think we need to be thinking about it very early, particularly in girls where osteoporosis is, such an important thing in their future, and realizing that it starts so early, and not just exercise, but dietary things like, not giving away milk and substituting soda for milk and all sorts of things that happen in the teenage years, which really are important for long-term health.
Wow. So peak bone mass around age 28-ish?
19, 20.
Yeah.
Yeah.
Well, for females.
For both males and females.
Yep.
Yeah, that's when the femur gets its peak sort of bone density around 19 or 20.
And then muscle mass?
Muscle more like 30. And it stays pretty constant till around 45, 50. And then it does start to go down, at least 5% per decade, probably. Over time, if you look at the, cross-sectional studies of the anatomical studies of Lexel and things from the 80s where he did, biopsies, or actually looked at the entire quadriceps of people who died suddenly with no disease, they had, lost 50% of their muscle mass without any disease from age sort of 8 to 80. So that's what happens without any sort of attempt to, do something different. So it's drastic that, you're losing half your muscle mass. And that's without diseases that make that even a little bit worse. So that's really the key thing that happens, I think. I mean, everything, is that happens with aging, can probably be improved a little bit. But, if there was one thing that we could prevent that would improve people's quality of life, it would be maintaining their muscle. Absolutely. Even more than maintaining their bone, because you don't fracture pretty much unless you fall, right? Except for your thoracic vertebrae. You have to fall to fracture. So the thing that makes you fall is not your bone density, it's your muscle and your
muscle.
So if you don't fall, you're going to get rid of 95% of fractures. So even if you did nothing for bone density. So to me, although all of the impetus has been developing drugs for osteoporosis, which improve bone density, absolutely, but they don't prevent falling, and they don't prevent frailty, and they don't prevent, other causes of disability besides the fracture itself. So they are never sufficient. They're important, but they're not sufficient for the whole syndrome, essentially. And, the way I think about it, if you think about somebody who comes in with a hip fracture into the emergency room and, she gets her, fracture treated by the orthopedic surgeon. She gets physio probably afterwards for, depending where you are, 6 weeks, 12 weeks. And then she's discharged from physio as soon as she reaches her baseline. As soon as she's back to baseline, physio stops. So if you think about that, baseline is the next day she fell and broke her hip, right? That's what her baseline is. So getting somebody back to baseline is so inadequate. It's so pathetic as a goal, right? So the goal is much higher than that. The goal is to get much better than you were the day before you broke your hip, because hip fracture is really a frailty syndrome. It's really what it is. It's a bone living in a frail body that falls over, and it maybe is malnourished, and there's cognitive impairment, maybe depression, maybe isolation, maybe polypharmacy. There's all these things going on which have nothing to do directly with osteoporosis, or some of them do, but the main point is they're not fixed by fixing the bone. So if you have a child who falls, off a slide and breaks their wrist, yeah, you can just fix the bone. The child's fine, right? Because the only thing that happened is, they fell from some height. But if you fix a bone in an 85-year-old woman who's frail, all you've done is fix the bone. You have not prevented her from having another fracture or from having other sort of negative consequences of frailty. So that's really the point of being a geriatrician, is to see how everything's related to everything. Nothing is out of scope for a geriatrician, which is why it takes me 2 hours to see every new patient that I see, just me seeing them, because everything is related to everything. And there isn't a single drug that I don't look at, or nutritional thing, or psychological issue, or social support issue, or medical diseases, that I don't think about when I'm prescribing exercise and medicine for that patient.
It's really interesting. I just thought about this. You're the one who is the future self. You understand what that future self should be to be optimized. So if you were talking to, a 20-year-old and she was basically saying, hey, I'm not sure, what my future looks like. How should I prioritize how I take care of myself to be able to just crush it when I'm 50 or 60 or 70 or 80? How do you do that? What's the playbook? What does that look like? So say she's 20 years old right now, and she is saying, I want to talk to my future self. I want to be able to visualize what that's going to look like. Because all day long, all we hear from our longevity brothers and sisters are, hey, you want to live long and well and all the rest. That's special. Thanks a lot. But what is the playbook to actually take a 20-year-old woman all the way through those decades with just a basic template to be able to assure that she has maintained and built as much muscle as she can to be able to live and thrive during all this time? So what's that blueprint look like?
Right. Well, I think the problem is that for a lot of young women, the focus is on fat and on obesity and losing fat. And the problem with that is that if you diet and that's how you lose fat, no matter what the diet is, doesn't matter, you'll lose, about 40% of the weight you lose is muscle and bone. And what that means is that as you, get off the diet, which usually happens in most cases, you will have a lower metabolic rate because your muscle mass is lower. And so it will be easier for you to gain back weight, even if you don't, eat as many calories as you did before, which is this yo-yo dieting phenomenon that we see so often. So the more you diet, particularly if it's in these sort of young, adolescent to early 20s years, you're thwarting that achievement of peak, muscle and bone that you should have gotten. And so you're ending up with a low metabolic rate. And then by the time you hit menopause, things get even worse because estrogen is now gone, which was protecting your muscle and your bone to some degree. And so it's sort of downturn. So I think that what you need to sort of shift, is the focus from fat and obesity to fitness and muscle health, which requires, active kinds of movement that are anabolic, if you will. And also a diet that is anabolic, meaning it has enough protein in it to sustain, muscle growth and function. So it doesn't have to be lifting weights. It can be, and particularly for younger women who are, premenopausal, impact exercise is as good or better than lifting weights in terms of bone, and also obviously increases muscle power. So those kinds of activities, if you can incorporate them in the course of some kind of exercise routine, or even just by itself, jumping, by itself, is really quite powerful, I think, for both muscle and bone. And also, focusing more on the aspects of fitness and health rather than body shape and things. And I think that, that is good, is hard, because obviously social media and everything is, although, if you start clicking on links to, weightlifting, then that's all you get on your feed. And pretty much, there are lots and lots of things out there on social media now about weightlifting for women in particular. So it is changing. It's changing its sort of face in terms of what it looks like to be a woman who's lifting weights. Looks quite different than it did maybe, 40 years ago. But I think, having a thought that what you do now when you're 20 will impact what you look like and feel like when you're 80. But I think, for me, it's also about having, a purpose in life is equally important. I mean, there are lots of studies about, the longevity benefits of altruism and empathy, altruistic volunteering, not forced volunteering. Those things make you live longer, to the same degree as aerobic activity does, a couple years longer if you just are, empathetic or altruistic. So, I feel like it's very holistic. Like, you have to have a noble purpose in life, if you will. And if you do, then you will probably take care of yourself to be able to actually, fulfill those kinds of goals. And because you can't, care for other people if you haven't really cared for yourself in a way. So I think it's really a combination of having a purpose in life that you want to achieve, and it's hopefully a noble purpose of some sort. And then thinking that you have to be healthy in order to achieve that. And I think as you get older, the focus on exercise shifts a bit from when you're very young, it's really about aerobic activity and maybe this impact stuff. And then as you get to middle age, you have to add the weightlifting. As you get to older ages, it's really about weightlifting and balance training. Aerobic will come, but it's not the focus of what we do for very, older adults. Because if you think about it, the very first study we did at Harvard at the nursing home, we were trying to recruit people for our weightlifting study. And we went to the auditorium and everybody came down, and then, and we were like, oh, you want to join our study? We're going to be lifting weights. And they're like, really? I said, well, why would you want to, do exercise? What would, do you want to live longer? And they looked at me like I was crazy. Like, we're 90-year-old Holocaust survivors. We're good. And so I said, well, what would make you want to lift weights with us? And this little man in the front row stood up and he said, what I want is, I want to be able to get out of my chair at night by myself, walk to the bathroom without calling the nurse, come back and go back to bed. That's what I want. I said, I can give you that. So if you think about it, to get out of a chair, that just requires strength, nothing else, right? Plus a little cognition. To stand up and not fall over, well, that's balance. And then to walk across the room or down the hall, that's where aerobic capacity kind of comes in. So that's the sequence that we always look to. That's what we, how we sequence our prescriptions, because it makes no sense to drag people who can't support their body weight through the parallel bars like you see in physiotherapy gyms, when clearly they can't support their body weight. So that is a matter of, misinterpreting what's wrong. And I think it happens because people go into the hospital, they have pneumonia, they go to bed, then they try and get out of bed and they can't walk anymore, right? Because in that short period of bed rest, they've lost 20% of their muscle function or more. And so what do the physiotherapists do? Well, they say, well, you can't walk, so I've got to make you walk, right? But what they haven't realized is the reason they can't walk is the loss of muscle. And so if you don't address that with the only exercise that does address that, which is weightlifting, they're never going to be able to walk again. Or you're going to be dragging them the hallway or making them use an assistive device, because they can no longer support their body weight, when really you should have just taken a step back and say, okay, let's restore the muscle mass first. That will allow you to walk again. So I think in clinical practice, there's a lot of misinterpretation of what is wrong and how to fix it. So it's not rocket science. It's really what my grandmother and Jack LaLanne taught us back in 1960. That's what it is. That's really what it is.
I love this. And, I'm like a crazy person about getting on my little soapbox and saying, from as early as you can do it, integrate strength training at one level or the other into your life. And so that it becomes integral. It's like brushing your teeth. Of course, I'm going to, strength train and all the rest of it. And I think that if we lay down a foundation like that from the beginning and make it interesting, make it functional, make it entertaining. There's a reason why I'm a triathlete. There's a reason why so many women are showing up for the triathlon. Because it's interesting. It's like, you don't like running too much. Well, maybe you like swimming. If you don't like swimming too much, there's always biking. It's just mix it up.
Yeah.
Make it look interesting. And get ready to shift. For years, I never touched a kettlebell, didn't understand them, didn't know what the hell they were. And then one day, my trainer showed me, how to play with it a little bit. I'm a very strong woman. I'm just more mesomorphic, a little more muscular. So I took to it like a fish to water. It's like, bring that damn thing to me. And I'm sitting there doing those swings and I'm doing the deadlifts and now I'm a kettlebell queen. I just love this stuff. And so what did I just say? I said that for years I never did it. I just shifted over. I found something else to play with. It's like one big playground out there, no matter what you do. And I've hiked the Grand Canyon twice, rim to rim. It's an exact marathon, 26.2 miles in 2 days. And, tell me that wasn't using just about every faculty I own. It's just, but I had fun. We had people there and it was like, whoa, we have to turn this into something that's not a grind.
Right.
It's got to be something that is understood from the get-go that has multiple benefits. Yes, you will look more toned. Okay, that's good. But it's not the only goal or objective or whatever. The key thing is, are you building a strong foundation for health and mental and physical fitness? Are you doing that? That's the key because, you and I are here past the age of 50. And you and I could sit here and say, okay, from my vantage point right now, what I'm actually seeing is why I had to be lifting weights all those years. It's interesting, Maria. What I would do during my medical training just to de-stress was treadmills became a thing, if you remember. And everyone was, fighting for treadmills at the club. And you didn't have the big clubs yet. You just had more boutique-y things.
Yeah.
And so one day I was at a boutique-y one and I came in and I had an afternoon and I thought, okay, I just got to burn off some stress here, and there I was. And I was on what I love to call the dread mill because it was so boring. And then I got a little tap on my shoulder and it was a handsome young, trainer. And he said, listen, could I just ask you a question? How come you keep showing up and you're always just doing this? And I said, well, it's the only thing I ever knew that you're supposed to do. And he said, no. He said, come on over here. I'm looking at your body. You look pretty muscular. I think you're going to like this. And I said, what are we doing? And he said, we're going over to the weights. I said, where the guys are? and he said, hell yeah. And so he brought me over and it was a nice quiet time of day. So there weren't a lot of guys. And he just started showing me the basics. And I took to it like a fish to water. And I never looked back. To this day, I wish to God I remembered that guy's name. I wanted to thank him. No, but I'm not even kidding you. Yeah. It's these golden moments. That was a gift to me. That was priceless because I have been lifting weights for 40 years. And I'm just saying that I didn't even realize I was saving my own life.
Right.
I didn't know. And now what you and I are trying to do as physicians who are also doing fitness, right, is to give a heads up to the people who are coming through now, in addition to giving hope to people who are already right there, age 65, 70, 75, whatever it may be. We have a playbook there too.
Yeah, I mean, most of my patients are 80 to 100. I deal with people who are very, frail and kind of at the end. But, we do have a very, I think, good program in that we, everybody, pretty much that I see comes to exercise in our clinic 2 to 3 days a week. And the clinic is right attached to my office. So it's, I'm there and it's very clear to them that it's part of their medical care. But it's also a very good social environment for them. I cook for them because I like to cook, but I also, take care of them medically, and they form very close relationships with the staff, with the other patients. And, they do have a sense of hope and they have, innumerable medical problems. I mean, they come, back from having hip fractures or cancer or heart attacks or strokes or whatever, and they come back and, rejoin the class, the individual sessions. So I think, it to me as a geriatrician, I like taking care of people who have lots of problems, if you will. It's much more satisfying to me to take care of somebody who's really struggling and really frail and has all sorts of things that they need help with, as opposed to, a 20-year-old who just wants to sort of lift weights, for the future. And I do see that there is a lot that you can do even at very advanced age, and that it can be fun, but we don't substitute the social environment for the exercise. I mean, the exercise is medicine. We make them do it at a high intensity. We progress. We measure their changes in 1RMs and outcomes, and we do want them to enjoy being there, but we don't turn it into a group like gentle exercise class where, the thought is, well, as long as they're coming and they're together, that's a good thing. And there are some benefits to that, but to me, that's not the medicine bit of it. And I think, and there are studies, Andrea Dunn's done a good study looking at, exercising in a closet by yourself or in a group, and the same depression outcomes happen if you do the exercise, whether you're alone or in a group. So the group is not critical. And I know for myself, I hate to exercise with other people. I like to exercise alone. So don't ever put me in a group exercise class when I'm 90. And some people like groups, some people don't, and I think the idea that you need to be in a group for that social benefit is not true. I think the psychological benefits are there if you do the right kind of exercise, no matter what setting you do it in. And it should be a setting that you like to do. And Abby King, again, has studied that, looking at people who were exercising at home or in a center, or they were given a choice to be one or the other. And the people who adhered the best were the people who were given the choice. Do you want to be at home or do you want to be in a group? Whereas the people who were forced to be in a center when they didn't want to be, or forced to be at home and they didn't want to be, they dropped out at a higher rate. So I think we need to be a little bit expansive about our views as to, what is the best way to deliver it. The best way to deliver it is the way that people will do it at the highest rate. But you still have to be delivering the right exercise. And I think a lot of people misinterpret it, the best kind of exercise is the exercise people will do. That's not really true, because if you look at the literature, certain kinds of exercise work and certain kinds of exercise are the control group for that RCT, right? So in our randomized trials, all of the, controls get sham exercise. They get a gentle exercise class where they're kind of, moving around. But we know it's not physiologically beneficial. And we know it's not even psychologically beneficial compared to structured, robust, versions of exercise, whether it's aerobic or resistance or whatever it is. So I think, I think all along the lifespan, there are reasons to incorporate it in a fun way, as long as, what you're trying to achieve is clear. I'm all about the evidence. I don't disseminate anything that isn't evidence-based. Whether it's for depression or sleep or bones or whatever, there has to be evidence that it will work for that. And even if people want to do something different, if I know it's not beneficial, well, why would I give them a placebo, which will work a little bit, but it won't work as well as the real pill or the real exercise. So I think that, combination of attending to the evidence, but making it desirable and feasible is really what you have to do.
When we come back, I'm going to ask Dr. Fiatarone what to do in this kind of situation when a 55-year-old woman came to me and said, "Oh, I could take time off from working out, no problem. My muscle will come right back. I have no problems whatsoever." The Her podcast is sponsored by Solaray Vitamins, Minerals, and Herbs, all rooted in nature. In addition to women's multivitamins, Solaray, Solaray, is presenting the new Her Life Stages products, providing support for the menstrual years, including PMS, perimenopause, menopause, and postmenopause, and even libido. This integrative, holistic approach has a woman's back throughout her entire life journey. To learn more about Her Life Stages, you've got options. You can run on over to your local health food store or check it out at Whole Foods, Sprouts, Amazon, or scroll over to solaray.com and use promo code HER20 for 20% off your purchase. Women, Solaray's got your back. And we're back. Okay. So what about that 55-year-old who just sat there and said, I took a year off, whatever, I'll be fine. When I was 20, stuff came right back. No problem. I'm a woman. I could build muscle.
Well, I think that's probably, the worst time in your life to make that decision, because you're right in that, 10-year sort of perimenopausal period where the estrogen, has gone away, and you're at the most risk for losing muscle and bone, and you lose it at a faster rate than you do, after age 60. So I would say, that's when women are in general gaining fat, losing muscle and bone, and then all of the kind of consequences of that shift in body composition, which I've always thought, body composition is kind of the major thing in terms of health span and aging, is these drastic shifts in body composition that occur at midlife and beyond underlies almost every chronic disease we can think about. Cardiometabolic disease, renal failure, dementia, depression, sleep disturbance, arthritis, almost every condition that we treat has something to do with that body composition shift at midlife. And so that's the absolute worst time to think like that. The withdrawal of estrogen means you need an anabolic boost to counteract that at that time more than ever. And it is true that if you stop, you can regain the gains that you've lost. But it's awfully hard to regain bone and muscle to this. You can probably stop the loss. But in terms of regaining it, I think, it's a little bit harder to do that. Strength is different. Strength you can regain much more quickly. But when you lose a significant amount of muscle, that in my experience is harder to reclaim. So I think there needs to be a real understanding that, stopping at age 55 is really going to set that person up for frailty and hip fracture, et cetera, at age 80. And so, a thought about the future is critical at that time point. And it's hard because you're not feeling weak or frail, or, you don't have any difficulty climbing the stairs or getting out of a chair. So you think, well, what's the matter with me stopping? Because I'm fine. So I think, but even balance starts to go down a little bit at that age. And so, and that's again related to changes in muscle to some degree, as well as cognition things. So there is a reason to, think about your future self, as you said earlier, decades before you get there. I think it's really all about prevention. I think I do a lot of treatment because people come to me at age 85, but in reality, it really is about prevention.
It's about education too, because you see, if you're 20 or 30 or even 40, you don't know. No one has sat you down and said, okay, this is kind of the way it's going to roll. In general, if we're just looking at the bell-shaped curve, now you're in perimenopause. You've got sex hormones that your body is weaning off, right? What is the impact on your bone, your muscle, right? Let alone your brain, et cetera. And how is that going to figure into your functionality, just your physical functionality in general? It impacts sleep and all the rest of it too, but I'm not going to get into that. And then as you enter your 50s, and now you really did hit menopause, assuming you're not on menopausal hormonal therapy, now we've got problems because now you're starting to really dip and you don't even know it. It's silent, unless you just immediately took a DEXA scan and you did a body composition analysis to really look at your lean body mass as well as, the bone density, et cetera. You don't know. I'm watching women just literally have no clue.
Because what you see is that your body weight's going up and you're gaining fat around the middle in particular. Your first impulse is to diet and lose the fat, right? But at that same point, you've already started to lose the muscle and bone. And I think that hidden, change is what, and we've done a study at Tufts a few years ago looking at longitudinal changes in body composition, and people who are losing weight after old age or after age 65, they're losing, muscle and bone along with fat. People who are gaining weight are the only ones who actually increase their muscle and bone. Even people who are weight stable, they're still losing muscle and bone. So, weight stability, which is kind of what people go for usually, that's what they're sort of happy about. My weight's the same as it was 10 years ago. If you look inside them, they actually have just made a shift. They've changed fat, and muscle percentages because they're not, doing weightlifting. And the only, way that's been shown to avert that is weightlifting exercise. So Klitgaard did a good study in 1990 where he looked at men in Holland who were sedentary, which was hard to find, sedentary men, runners, swimmers, and weightlifters. And they were 75 or so at the time. And he looked at all sorts of things about their muscle in terms of mass and did biopsies and electromyographic studies and strength. And he compared them to men who were in the lab, who were just young, healthy men in their 20s. The older athletes had been not elite athletes by any means, just recreationally active men for at least sort of 15, 17 years. And what he found was that the swimmers and the runners had lost about 50% of the cross-sectional area of their muscle, comparing them to the 20-year-olds. They were 50% smaller, the muscle fibers, even though they'd been habitually running and swimming for 17 years. The older weightlifters had muscle that looked identical to the 20-year-olds in terms of mass, EMG characteristics, strength, et cetera. So they didn't look like 20-year-old weightlifters. They looked like 20-year-old healthy men. So basically what that means, because obviously, Arnold Schwarzenegger doesn't look the way he looked 50 years ago, steroids or not.
I was going to say.
Jack LaLanne, also changed a bit over the years, despite, no steroids, obviously. But they did look like, healthy young men, even though they were 75 years of age. So they had pretty much averted all of those age-related changes in muscle by the fact of lifting weights, which aerobic exercise didn't do. So that really is, tells us that there's a radical difference between these two medicines. Aerobic exercise is great for certain things, but there are certain things it does not do, which are pretty much in the category of muscle and bone and balance. And so when you get somebody who's 85, it's pretty clear that what's afflicting them are the changes in muscle and bone and balance and cognition. Yes, they do have lower aerobic capacity, but that's not really what is limiting them in day-to-day life. And the good news is that if you just lift weights, you increase your aerobic capacity by about 10%, 12% in studies, which is pretty much the same as moderate intensity continuous aerobic training. About 10, that's all you get when you're older and you start aerobic exercise. The only thing that's better than that is HIIT training, which, you might get a 15% increase in aerobic capacity. But so, if you only do weightlifting, you get aerobic benefits, you get cardiometabolic benefits, you get lowered blood pressure, better sleep, better depression, and increased muscle and bone. Whereas if you just do aerobic training, you get the cardiometabolic stuff, but you don't get the other. And so I think, when I look at patients and I look at, well, what do you need? What do you have to have? You have to have the weightlifting. If you can add aerobic on top of that, great. But a lot of my patients are too frail to do much. They can hardly walk across the room. So I can't tell them to go walk on a treadmill or go out for a walk or, take a bike ride. They can't do that. So I give them the thing that they can do. that will then lead to them to having enough mobility, hopefully, to do the aerobic stuff. But doing it in a different order, absolutely doesn't work.
You remind me of something too. When I was at the National Institutes of Health, I was a senior research fellow. Most of my work was done with glucocorticoids. And we were looking at Cushing's syndrome and why we got this big belly with Cushing's. And this helped add a piece of the puzzle to the metabolic syndrome as we looked at glucocorticoid or cortisol expression in fat cells in the intra-abdomen. And so there I was working away and whatever, and I befriended someone who was in the administration in Building 1, where the director is. And this lovely woman was 65 and was getting ready to retire. And she was just absolutely classic. She was, had sat at a desk for years, was very sedentary. She had pretty good belly on her. She was just not fit. She knew it. And so she came to me and we were just talking, and I laid down the law. I said, girl, you are doing strength training. And in addition, let's start adding some other stuff too, like balance and this and that, because at your age, whatever. So we started doing that, and the months went by, and she was really doing well. She had dropped just a load of the weight, cleaned up her eating and all the rest of it. And then one day I was in my office, and in she came. She was already retired now, and she showed up, and she was tracking in mud from her rose garden. I thought, oh my God, what a mess. Who's doing this? And she had this huge bouquet of roses that she had just cut from her own. She was very proud. This was in Bethesda, and she had one of these gorgeous, gardens. And she just had this look on her face. She said, these are for you. And I said, why? And she said, because I was pruning my roses. And in order to do that, I had to step up 6 steps. These were stone steps, right? She had a 2-tier kind of backyard thing. And I was, clipping away and working with my roses, my beloved roses. And then out of the blue, this 35-pound garden spider shows up. It's like, it just dropped down. It's like, boom, right in front of her face, shocked the pants off her. And so what she did was fascinating. She went backwards. And since she was strong, she had strong arms, strong core, strong legs, good balance. She was able to grab a branch, nice strong branch, and not fall down backwards on the stone steps. Because at one point, as she was holding on real strong and she was not going to let go, she looked backwards. She saw where she was going to go.
Right.
And she stopped. And then she stood up and she said, so this is what Dr. Peak's been talking about. I saved my own life. I could have died. So I accepted the roses, and it took us 2 hours to clean up the mud. But at the end of the day, that's what made me the happiest of all.
Yeah.
Because that's what this is about. It's functional. It's staying alive. It's assuming the vertical and staying there. And when I look at your marvelous work, I say to myself, how many young women who are 20 and 30 and 40 and 50 know what they really need to do, the essential elements to be able to optimize their bone health, their muscle health, and then to manage fat?
Yeah.
That's really at the end of the day, because I'm with you. I have never cared about weight. I don't even know what it means, right?
Yeah.
I don't know. I want to understand what body composition is. You tell me what your percent body fat is. You tell me your total lean body mass. I was the first person to use DEXA scanning for body comp at the NIH. I dusted off some DEXA scanner in the basement. Somebody had bought the thing from radiology and never used it.
Right.
And I found it. And I was so excited, and I got a radiologist to help me. And we ended up doing that for most of our body comps on the Cushing's patients. And that's when I really developed a respect for the quality of your body.
Right.
Not just the quantity, but the quality.
That's right.
Because
yeah. And I mean,
does that make sense?
Now with, the newer drugs, the, Ozempic, et cetera, which all, are obviously focused on the fat. It's just sort of coming out now how bad it is for muscle and bone to take those drugs. And there are some studies showing that if you take Ozempic plus do weightlifting, you can avert the loss of lean tissue. But obviously most people are not doing that. Most people are just taking the drugs and, now supporting the entire economy of Norway, I guess. But that's the problem, is that the focus is on the wrong thing. And, when I look at diabetes, it really is it's a combination of too much fat and too little muscle, because the muscle is the sink where all the glucose goes, obviously. And, if you don't shift from that kind of catabolic milieu to an anabolic milieu, you're never going to really optimally treat type 2 diabetes. And for way too long, our focus has been on the fat and not on the muscle for diabetes care. And I think, that's really what has to shift. And physicians don't know that. Physicians don't talk about muscle and diabetes at all. They still counsel their 80-year-old people with diabetes that they should be losing weight. And I'm like, no. If you make her lose weight, she's going to actually lose more muscle. That's not the solution. Let's just, keep her weight the same even, but increase her muscle. That's going to improve her glucose sensitivity, insulin sensitivity, and be better for her in many ways, than if she lost weight, which absolutely is going to come with loss of lean tissue. So that focus, it's not there in medicine. I mean, there are no courses really in sarcopenia in medical school, just like there are no courses in exercise. And the reason really, I think, is that we don't have a drug for it. I think that, when I was at Tufts, there was a lot of interest from Pfizer and lots of companies to develop that sarcopenia drug, right? As soon as the name came out, they're on it, right? They're trying to develop a drug to treat sarcopenia. None of them worked. They gave up after, a decade or so, because everything just caused, carpal tunnel and diabetes and, just doing the wrong thing. And to me, I did a couple of studies where the control group was weightlifting and the intervention group was the drug, to see if they could get a drug that was, would have the same, kind of effect that weightlifting did. And I did it just to prove that, in fact, weightlifting is the right drug. And, but to me, it was like always, well, we have the drug. We actually have the drug for sarcopenia to prevent it and to treat it. We have it. You can't market it. You can't put it in a bottle. You can't, prescribe it in the way you do a drug. But we have it. But because, things are controlled by big pharma, that isn't the way it's gone. That isn't the way doctors are taught. It isn't what they learn about. They don't know how to prescribe it at all. If somebody's not active, at best, they say, I think you should go take a walk. It's pretty much, what most doctors will tell patients. Even when they come to them and they say, Doc, I can't walk. My knees really hurt. What do I do? And you should walk more. So we never do that. We say, I can't walk because I'm in pain. I say, okay, don't walk. Sit on this machine, lift weights, and that will allow you to walk. But that, shifting of the sort of focus isn't part of medical training, unfortunately. So I think patients have to kind of almost get their own, education about it, and tell the doctors, what it is they want. And because it isn't a drug, it's not paid for by, the health insurance companies. And I mean, the only time that was different was right after the DPP, the Diabetes Prevention Program, which was done at the YMCA. And for a time, United Health gave people free YMCA memberships for 2 years if they had metabolic syndrome, to replicate the DPP. But that went away after a couple of years, I think. And so that was the only time where exercise was paid for by healthcare to prevent a disease, right? To prevent diabetes. Because now we don't do that. We pay for it for cardiac rehab for a few weeks or for, something like that. But we don't pay for it to prevent disease. Same thing in Australia. We had a couple of years where we replicated the DPP here, and we said, okay, there was a Medicaid number that if you went to a program that was a diet and exercise, et cetera, you could have that paid for by Medicare. And that lasted, I think, for 3 years, and then they got rid of it. And again, that was the only paid for preventive use of exercise in medicine. And now, again, it doesn't exist at all. So people are forced to, pay out of pocket, and, it's quite expensive to go to trainers or, join a gym, even for people who are on pensions. And so, it's not part of the healthcare that's paid, but they can get metformin for life to prevent diabetes, right? That's paid for.
I know.
And it works half as well as diet and exercise, half as well.
Exactly.
And in fact, in old people, it's no better than the control group, if you look at the DPP. So the thing that we pay for in older adults to prevent diabetes actually doesn't work, but we don't pay for the thing that does work, which is the, structured lifestyle advice. So, the priorities are all wrong. The priorities are driven by pharma, I'm sorry to say, and big food, and big pharma and big food together, so that's the problem.
You know something, Maria, I could talk to you forever, and I would love to do that, except for the fact that it's like 8:30 a.m. for you and you're ready to start your day. And it's late for me, and I'm ending mine. And this has just been absolutely a delight to get a chance to, no, I'm not kidding, to connect with the kindred spirit, because I think we're quite fully aligned, needless to say. And what I'd love to do is have you on again to continue this conversation, because I think that there's so much to be said here, and we've just begun to, touch on some of the bigger issues and challenges as they relate to a woman in this case, I'm saying a woman, trying to optimize her body composition throughout life. And that's kind of, where it is. So with your kind permission, you will become what we love to call a repeat offender. That means that you'll be back more times than you can count, to say the least.
Happy to be here.
Everyone,
for inviting me.
Yeah, I mean, seriously, everyone, we've been talking to Dr. Maria Fiatarone, and she is hailing us from Sydney, Australia. And she is an internationally recognized and renowned expert in geriatrics and fitness, exercise physiologist. So I just thank you so very much, Maria, for being on the
Thank you.
Wonderful, wonderful. And I want to also thank my sponsors, Solar Vitamins, Minerals, and Herbs, all of which are rooted in nature, and the new Her Life Stages products. You need to scope it out at Solaray, SOLARAY.com. And everyone, take a moment to leave us a review, because we're all about feedback. We love it, love it, love it. And this was such a great show. All right. So this has been a production of Podcast Health. And remember, your time in this world may be limited, but the things you can do with that time are not. So go on out there and seize the day. A little bit of carpe diem, please. Thanks, everybody.